hypoglycemia risk and achieved A1C is opposite in type 2 diabetes to that which we see in type 1 diabetes, where there's a clear relationship that is increasing as the hemoglobin A1C decreases, but it's the reverse in type 2 diabetes. This is really quite hard to get our heads around at times. And indeed, despite the fact that the ACCORD study is the largest as yet study that involves patients specifically with type 2 diabetes, actually many commentators put this observation down to a study effect. So the assumption being it wouldn't be true in real life. Actually, however, in the years since ACCORD, people have been looking at their populations, and at this year's ADA, there were 3 or 4 separate presentations of population data looking at this question, one of which came from the Kaiser Permanente group. And what we can see, this is a surrogate of those studies. What we can see is on the left panel, we've got the type 1 diabetes, and there's clearly this relationship with lower A1C, higher hypoglycemia risk, confirming the DCCT data. And on the right side of this panel, in a slightly different format, it has to be said. So in this format, the grey represents people with A1Cs under 7, the yellow 7 to 8, the grey triangles 8 to 9, and the squares above 9. What we can see is that the risk of severe hypoglycemia progressively rises as the hemoglobin A1C rises. So a higher average sugar level, but a higher hypoglycemia risk. So it is true in real life as well. So what that leads us to is if we believe that hypoglycemia is the thing that's getting in the way of our potential benefit, and that A1C is only relevant if the hypoglycemia is taken into account, what we clearly need is something that tells us more about glucose than just glucose exposure, which is what we get from the mean values or from hemoglobin A1C. And in fact, what we recognize then is that we need to look at something that looks at, if you like, glucose flux as well. And in clinical practice, there are 2 forms of glucose flux that we would all recognize in our patients. One is variability from one day to the next. So weekends different than weekdays, holidays different than working days, etc. And the other type of variability that we see is variability across the time of day. So mornings higher than evenings or vice versa. And actually when you think about it, it's glucose flux, not glucose exposure, that leads to hypoglycemia risk. Because we never target glucose exposure at a hypoglycemic range. So the only reason hypoglycemia ever happens is because of variability from that range. And that brings us to these things, the ambulatory glucose profiles. And I know that Ramsey's done a lot of my work already for me this morning because you've already had a talk about these. And I think I'm putting up this example of a profile. And just to quickly remind you, the dark blue line is the median of glucoses achieved by time of day over a 2-week period. So clearly, this person's median line in the mid-afternoon is significantly higher than their median line in the small hours overnight. The dark blue shaded area shows us the 25th to 75th percentiles of their data, and the light blue shaded area, the 10th to the 90th. So as I would look at this as a clinician, the dark blue shaded area predicts where this person's glucose usually is to be found at a given time of day, and the light blue shaded area predicts where it is sometimes to be found at this time of day. So this person, clearly, when you look at where his median line is, has got excessive glucose exposure. But he's also, if you look down at the sort of 8 o'clock period, got hypoglycemia risk. So to try and improve his glucose exposure is impossible without first doing something about his variability. And this sort of information, I think, is giving us a key insight into the sort of management steps we need to be thinking about for all our patients, but particularly those with type 2 diabetes, where we know that hypoglycemia causes a major outcome risk. So I've just made that same profile into a cartoon here and saying, well, actually, what is it we need to try and do if we want to improve the outcomes for this individual? And the first step is that we have to reduce his variability. So we need to narrow the profile. Once we've narrowed the profile, we need to do something else before we look at exposure. We need to actually flatten the profile across the times of day. Once we've achieved those two steps, we can very safely reduce exposure to a target level without increasing his hypoglycemia risk. So if we are to incorporate the evidence that we have from our large studies into better outcomes for our patients as an individual, the way in which we address glucose exposure and glucose variability is going to be as important as the final A1C number. And I think that then comes into us thinking about how we manage type 2 diabetes in the round, because our traditional view of managing type 2 diabetes has a fairly linear approach, which is we go from lifestyle measures to oral agents and lifestyle measures to, I'm suggesting actually it's fairly standard nowadays to be looking at once you've looked at oral agents, to be looking at a non-insulin injectable as a first injectable therapy. But then it may require insulin either alongside or instead of, and insulin intensification. That linear process doesn't tie in very well to this idea of what do we need to modify in a glucose profile to improve the outcomes for this person. And of course, all of us know that whereas it's easy to write something like that down on a piece of paper, the devil comes in the assessment processes at each step of this phase. That's where the specialty expertise comes in, is in making those assessments. And actually, the assessments lend themselves best to moving towards a slightly non-linear strategy of care, which is actually, I'm just going to give the best therapy at the moment that I can for this patient now. So rather than thinking what's next on the list, we have a slightly different progression process in an individualized therapy. What we now look at is we say, well, what's available to make a difference to what's going on? It may be he's on the right therapy, but either his lifestyle measures or his misunderstanding of how he uses it mean he's not using it optimally. So we could optimize his current therapy. And we mustn't forget that as a very major potential intervention. Or, of course, we could think about adding an oral agent to whatever therapy he's on. Or we could think about, if he's already on an injectable therapy, changing his injection therapy. Or we could think about adding a different type of injection therapy. Or we could think about something else, because there's lots around the corner. So I think it's almost every assessment statement, we've got the whole strategy set that we can look at. And of course, how we make those decisions is based largely on what information do we have. And we get information from a number of sources. I personally, the way I practice, feel that the most important information I receive at any given time comes direct from the patient, because that's the stuff that makes me aware of what's likely to be practical for an individual. But I think we also clearly look at the information that we get from investigation results. So, for example, poor renal function will cut out a number of our therapy options. And we look at what we're trying to achieve in terms of the overall risk profile of an individual. We have looked at glycemic profiling for a while, but we've tended to look at it just as A1C, and I say what I'd like to focus on a little bit is glycemic profiling in a slightly more detailed perspective. But I'd also like to look at where we actually have in terms of the evidence base about some of the therapies that we actually have available at the moment. And in that respect, I'm going to, as I say, look at these two groups, the once-weekly GLP receptor agonist dulaglutide and the premixed analogues. And I want to leave you with a rhetorical question. These represent 4 AGPs from 4 different patients, all of whom have a hemoglobin A1C above 8% and below 9%. I would challenge you to look at those 4 profiles, which in my eye show very different patterns of glucose risk, and say, oh, clearly the next step for all of those patients is drug A. That is not what we see when we look at glucose profiles. We look at the chap in the bottom right corner, clearly wants a very different type of therapy to the person on his left. And I think it's that individualization process that we need to start looking at. So, looking at dulaglutide, if we take the view that GLP-1 receptor agonists are the primary or first injectable therapy that we will offer to the majority of patients with type 2 diabetes, not everybody, clearly, when there are signs of insulin deficiency, insulin remains the right therapy. But for the majority of our patients, when they need an injectable, a GLP-1 receptor agonist is likely to get there first nowadays. So what does a patient want from a first injectable therapy? They want it to be easy, they want it to be convenient, they don't want it to be painful, they want it to work, they want it to help them with weight, and they don't want it to cause hypoglycemia. And actually, I think this slide is titled, What Does a Patient Want? I think you could quite easily title it, What Does Their Physician Want? So, with that in mind, dulaglutide has been in development for about 15 years. And what they took the view of is that this easy and convenient means you don't have to give it very often. And so what they've done is they've taken the original GLP-1 molecule and they've looked at modifying it by a number of different mechanisms to see if they can make it a more durable agent. And in essence, I don't think I have a pointer. Do I? No? Well, maybe I can use the screen pointer, can I? No, I can't use the screen pointer either. So if you look on the left-hand side of this, what you can see is the ringed amino acid change in the GLP-1 analog chain is specifically to try and prevent cleavage by DPP-4s in circulation. And then what they've also done is that they've made it into a large molecule by the addition of the IgG4-Fc complement, and they've linked those 2 things together using a specific amino acid linker so that there are 2 GLP-1 molecules per overall molecule of the agent. What that does is it means that basically there is no metabolism of this agent in the kidney or the liver. Its metabolism and its excretion are done purely in circulation by peptidases in circulation. What that means, of course, is it will have a prolonged duration and that renal and hepatic function doesn't impact upon its use, at least theoretically. And in addition, they made other changes to try and improve its solubility, because of course a soluble molecule means that it can be delivered in a solution, which therefore will require much smaller needles for injection than anything that is a suspension at the point of injection. And then they've also looked at the potential for immunogenicity of all injected agents. And so they've made a further change that helps to reduce its immunogenicity, in this case specifically around the T-cell epitope. And so what they're then left with at the end of their development process is a drug that's got a half-life of 5 days, so it can be used as a weekly injection, that's soluble, so it can be injected as a small needle injection, that really has almost no renal clearance at all, so renal function then becomes independent to its action, and that has a low potential for immunogenicity. Important statement is not no potential, it's a low potential. And when they've looked at what that produces, and it's probably worth just focusing on the graph on the right here, we see that its time activity curves are pretty much identical throughout a dose range. So it's got a very predictable half-life at whatever dose it's being given. And of course, if we look at the sort of national and international guidelines around the use of GLP-1s, we know that there's a variety of spots in the treatment pathway where they might be useful. And broadly, those could be either as a monotherapy, as a first-line therapy. I have to say in the UK that's not particularly common. Or as a combination with one other agent, or as a combination with two other agents, or as a combination with insulin. And so you won't be terribly surprised, given that those are the areas in which the drug is, or the drug class is already licensed, to see that when Lilly were doing their pre-registration licensing studies, they've done studies in all of those areas. The licensing study program is known as the AWARD program, which stands for the Assessment of Weekly Administration of Dulaglutide in Diabetes. And they've looked at patients naive to therapy, patients on one agent, patients on two agents, and patients on insulin. And I'd like to present you some of that data to give you a feel for the molecule. One of the things that Lilly did in one of their first award studies, although it's called the Award 5, it was actually probably one of their first ones, was to look at how we decide the most effective dose. And actually they did something that's quite refreshing, in my mind anyway, which is they did what we do as clinicians. They said, how do we balance the benefit against the risk of a drug? And what they've done is they've taken positive outcomes in relation to hemoglobin A1C and weight, and they've taken potential risk outcomes in relation to heart rate and nausea, and they've balanced those into a clinical utility index and then plotted where the most beneficial drug level is. And in this series of studies, that came out as a dosage of 1.5 milligrams per week, and so that is their standard dose. And they also have a second licensed dose of 0.75 milligrams per week, which is the dose which is licensed in people on no other therapy. All of the studies took basically the same process, which was to do a straight head-to-head against the comparator after an initial washout phase. And all of the studies had an initial primary target period and an extension period. So I'm not going to go through them all in great detail, you'll be pleased to hear. This is a summary slide of all of the award studies. Everything in the light blue colour is the effect of dulaglutide 1.5 milligrams weekly at 6 months. The yellow data represents the lower dose, 0.75, and that's in the study that was just to do with monotherapy. And what you'll see just by glancing across the page is that pretty much every study that was undertaken showed dulaglutide to have a superior glucose-lowering effect in terms of hemoglobin A1C to the comparator it was put against. And those comparators include oral agents, they include other GLP-1s, and they include insulins. The one which, as you'll see, comes closest is the one in the center of the page, which was the Award 6, which was the comparison data against liraglutide, which probably at time of publication anyway, was considered the most effective single agent for treatment of diabetes. And actually, the dulaglutide did marginally, although not statistically significantly, better than liraglutide. And I think when you look at the extension phases, what's encouraging is that the extension phases of these studies show that those benefits tend to be sustained over time. Despite the fact, however, that this is a long-acting molecule, the impact upon its fasting glucose levels happen very quickly. And in fact, this is a study from the comparison with exenatide, and actually, the fasting glucose reduction happens quicker with the long-acting agent than it does with the short-acting agent. In effect, it's getting almost all of its glucose-lowering potential on the fasting within 2 weeks of initiation, which is an interesting statement for a long-acting drug, because we normally think, don't we, about 5 half-lives to get to a steady state and all this sort of process. And certainly this got me to thinking about, well, how do these sorts of drugs impact upon things like overall glucose profiles? We got some information about how they impact glucose profiles from the award program itself using fingerstick measures. And what we can see is the profiles at the top of the screen here show the baseline profiles either of people who are going to be treated with exenatide or people who are going to be treated with dulaglutide. And towards the bottom of the screen, you see the profiles after treatment. And I think there's two elements. We would expect the dulaglutide profile to be slightly lower than the exenatide profile because we've seen that it has a greater hemoglobin A1C lowering effect. But I think what's important to recognize is that the reduction in the postprandial variability is almost as great with the dulaglutide as it is with the specific mealtime use of exenatide. Again, the summary data looking at weight is encouraging. So again, the blue data across the board is the dulaglutide data, and as you can see in all the studies undertaken, with the exception of the dulaglutide study, the dulaglutide has a significantly better weight loss. In the liraglutide study, liraglutide actually did cause slightly more weight loss than the dulaglutide, although it must be remembered it was compared against a 1.8 milligram dose of liraglutide. And I'm just going to flick back a couple of slides for a moment, which always upsets people looking at slide sets. Because when you look at the second panel on the left here, and this is actually true with all GLP-1 receptor agonists, the weight reduction effect of GLP-1 receptor agonists is the single most dose-dependent element of their process. So is one better at another? I think that's very hard to determine when you're looking at weight with GLP-1s, because the biggest impact upon the weight effect is the dose. So we'll move back forward again. So if we're going to look at trying to flatten profiles, and I'm sure Ramsey was talking about low, flat, and narrow, which is our sort of goal of an effectively managed AGP, then we need to know that we're having an impact upon hypoglycemia. And as you can see, certainly when you look at insulin as a comparator, the impact on hypoglycemia is significantly improved from the use of dulaglutide. And indeed, in this group of studies, as with the other GLP-1 receptor agents, hypoglycemia occurring is thought generally to be due to the combination therapy rather than the GLP-1 receptor agonist itself. Nausea is a side effect of this group of drugs, and I don't think we can claim anything else. It's not different with dulaglutide than it is with other agents. I think one thing that the formulation has allowed, and some of you may or may not have seen the injection device for dulaglutide, is it allows a really simple disposable injection device that is a once-use device. No needle is visible. There is a single pop it on the tummy, twist, press, and that's it. Nothing else needs to be done. And certainly that simplicity of delivery, I think, does make it an ideal first agent to think in terms of injectables. And if we look at an American population, 211 Americans who were treated with this as a first injection therapy of any sort, without any specific instruction, 99% of them were able to give a first injection without difficulty. And 99% of them, having done that, said it was easy. Now, what's almost more impressive is at the end of 6 months, 97% of them said they were happy to carry on doing it, which for an injection-based study is a very unusual result. So dulaglutide then clearly is relevant in weekly use, has a very simple injection process, is effective in terms of glycemia, and as I say, statistically is the most effective GLP-1 receptor agent we have in terms of glycemia, with a low hypoglycemia risk, and because it's not metabolized in the liver or kidneys particularly, theoretically at least, it's safe in those areas of use as well. I think there's a number of questions that we'll need to look about asking about it, which is, How do we determine its action onset? How do we look at side effects over time and pleomorphic effects over time, given that the whole group, it remains relatively new to treatment? But I think clearly what it does give us is it gives us a number of areas where we might think about using it, either thinking about using it early as an alternate to another oral agent, or using it slightly later as an add-on to multiple agents, where I quite like the idea of them as a routine in my practice, because of course I don't see many early diabetes individuals, is to look at it as an add-on to insulin, as an alternate to insulin intensification. And for me, that's why these two topics work quite well together. Or to look at it as a switch from another agent if the frequency of injection or the process of injection of another agent is causing problems for the individual, and that would therefore improve their concordance. I think what we shouldn't probably do is use it as a last resort, which is what we tend to do with all new drugs that end up on the market, and we therefore tend to fail to use them to their best benefit. And I think clearly there's work to be done and work ongoing in special group situations. So that's my thought about GLP-1s, and I'd like to just move straight on to a thought about how we look at the way we use insulins alongside. And I'd like to keep in your mind an individual who is on a premixed insulin, standard average dose, but despite which is achieving an A1C of 9%. Now, outside of patients with renal disease, in my practice, that is everybody I get referred in hospital. I get referred nobody with glucose control that isn't a problem. So this, I think, is one that we can all easily put in our mind. And realistically, in terms of insulin therapy options, if we just look logically at what our options are, we can say, okay, you're on a twice-daily mix. We could change you to a different twice-daily mix. Or we could change you to either basal plus or basal bolus. Or we could change you to a different way of using mixed insulins. And what I'd just like to do is just look at some of the evidence around those, because I think there's a lot of hype one way and the other sometimes about what's the right or the wrong way to go. And again, I think coming back to that, what we're trying to do is to achieve flat, low and narrow as much as we can. It has to be a horses and courses decision. But if we look at first the issue about switching to an analog premix. So of course, most of the studies about switching to an analog premix now are getting slightly long in the leg because they were mostly done at around about the time when these drugs were launched. But certainly when we look at the impact of those studies, the primary impacts of switching to an analog mixture rather than a human insulin mixture were on hypoglycemia following meals and on glucose variability, without a huge impact, for the most part, on hemoglobin A1C. So our UK-based guidelines for that process reflect that and say, so the reason for using an analog mixture rather than a human mixture is if someone wants to inject immediately around the meal, or has problems with hypoglycemia, or has already found that their immediate after meal sugars rise dramatically. Otherwise, we're not expecting them to be dramatically different. So it doesn't always produce a dramatic change in the A1C, and indeed, if we believe the data, if there is a dramatic change in the A1C, it probably wasn't the insulin, it was probably a behavior change alongside the switch that made the difference. What about switching to basal bolus then? Because again, we tend to think of that, don't we, as our gold standard often. And there's been comparison data looking at which is better, basal bolus or twice daily mix. There's a little organizational flaw in this study, in my view. It's a great study generally. The organizational flaw was its starting group were people who were failing on a twice daily mix, who got randomized to either twice daily mix or to basal bolus. So actually the group randomized to twice daily mix weren't really randomized to any significant change in therapy, and therefore the placebo study effect might be expected to be a little bit less in that group. But with that one critique aside, I think this is a good study. And what it showed is that if your primary measure of glucose control is the hemoglobin A1C, then those patients titrated up on a basal bolus therapy did achieve a greater reduction in hemoglobin A1C than did those on the premix. Interestingly, those on the premix achieved nearly a % reduction, despite apparently having been failing on an optimized premix at the inclusion to the study. I think the challenge, however, is when we look at the ways, and most of us, when we offer basal bolus therapy to our patients with type 1 diabetes, do so in a very proactive way. And we all recognize the elements of an education program and an adjustment process that make effective insulin decisions in basal bolus therapy when we're looking at type 1 diabetes. And they're very work intensive. They're very work intensive for us as educators, and they're very work intensive for our patients. Because the number of people with type 1 diabetes is relatively small, from our side anyway, we're quite happy to put that effort in. The challenge we have, and the rhetorical question I would ask you, is that what we mean when we're talking about basal bolus therapy in our type 2 population? And from my perspective, the answer to that question is no, it isn't. The majority of people having basal bolus therapy in the UK who have type 2 diabetes are not adjusting insulin doses. They're doing fixed dose, multiple daily dose regimens, which is a slightly different scenario to true basal bolus. And of course, most of the studies look at true basal bolus. And of course, even in research studies, people have found basal bolus challenging because of the requirements it puts on the individual to determine dose structure. Even with fixed insulin dosing, so take aside the issues of carb counting, etc., with fixed insulin doses, the monitoring requirement to make the adjustments to the dose are really quite dramatic and can be more of a burden than some people wish to undertake. So there's lots of reasons, and I've started a list here, but I'm sure you could make a bigger list yourself if we were thinking about it, about reasons why not every patient wants to switch to basal bolus therapies. Because we know that in our practices, as opposed to studies, when we put people on basal bolus, 2/3 of them don't achieve the target we perhaps set out to achieve in the first place. So, as an alternate to that, then, we can think of using a different type of mixed regimen that might put less burdens on the patient, but produce a better outcome. And the rationale for doing that is that when you look at patient groups in studies who have very closely adjusted their therapies to try and achieve good control, what you actually find is it doesn't matter whether that's done with injected therapies or with pump therapies in type 2 diabetes. What they end up with is a ratio between their long-acting and their short-acting insulin that is approximately 50-50. And we know that as we get towards the target hemoglobin A1C, towards the right of this graph, the impact of the short-acting insulin becomes greater than the impact of the long-acting insulin. So there are a number of reasons why mixture insulins with a higher percentage of short-acting insulin might well make sense. And I think that's particularly true if you look at those mixtures in a regimen which is going to be 3 times a day, because when you're giving a 12-hour basal insulin 3 times a day, you actually achieve a very flat basal insulin profile across the day, which is what we try and do with our basal therapy analogues. This isn't that. This is twice daily high mix insulin compared to standard formulation mixed insulin. And what you can see is that in the red line here, the glucose excursions after meals in relation to the high mix are far less than the glucose excursions after meals in relation to the mid-mix, and you'd perhaps expect that. When you look at that in terms of how does that affect the control overall, again, similar to the data looking at twice daily mixtures versus basal bolus, there is an improvement in control of a similar degree using 3 times daily 50-50 mixes as compared to twice daily standard mixes. I'd like to share a patient with you. So this is Marjorie, who I've actually known for some years now, mainly actually through admissions to hospital rather than through the clinic, sadly, but there we go. She has been on Humulin M3. She takes about 30 units a day. She does take tablets as well, but I'm going to ignore the tablets for the purposes. And this is her glucose profile on 30 units of premixed insulin a day. And what we can see is, if we look at the blue line, she has a median of about 10 millimoles across the day, so a little bit higher than we might want. But she's got really pronounced variability with all of the meals of her day. So if the A1C or the mean tells us one thing, but the variability tells us something else. It tells us that if we wish to try and reduce her median and her exposure, the only way we can do that safely is by reducing her variability first, so that the episodic, usually around meal times, low sugars that she has don't start becoming hypoglycemic problem areas. So we put her on instead to a mixed 50 regimen. You'll notice that the dose of insulin overall is very similar. She now takes 14 units in the morning, 6 at lunch, and 12 with